Today's class is about one important spotter, that is drugs related to leprosy. Okay, but I thought about the class is on national program also, just the key points. Okay, not nothing else. So leprosy caused by, so what is the first diagnostic test we can do about? AFB korbo using split skin smear. কোত্থেকে নেব? স্কিন লেসন থেকে নিতে পারি, আর তাও কি যে কোনো জায়গায় স্কিন লেসন হলে সেখান থেকেই আমরা নিই। টিপ অফ নোজ, ইয়ারলোব, আর চিক, আচ্ছা, আর এনিথিং এলস? জয়েন্টের কাছে হচ্ছে গিয়ে নেব ওখান থেকে। How many samples usually taken? This was in micro, na? Lab dag. How many skin samples has been taken? 4 sites possible. And so, do we take nerve sample? What is the most common affected nerve in leprosy? Ulnar nerve, followed by, that is most common actually, motor nerve. You can say ulnar nerve if the no options is given. We all know now what is the most common region it affected. There we prick a pin. So now pinprick is also sometimes it's called it causes bleeding. So we use a blunt end, sometimes the blunt end of your hammer, sometimes even a match. Okay, একটা দেশলাই দিয়েও করা হয়. It depends. Okay, place to place. Next, thickened peripheral nerves leading to nerve damage and muscle weakness. Muscle weakness is due to nerve damage. Okay, the innervation is lost, so the muscle loses its function, finally damage. You have to know a bit about the history, okay, because NLEP is one of the oldest program. Okay, even British have a program for leprosy cases. Okay, so first ancient even ancient scriptures. Okay, there are not many sun temples in our country. We all know about one, that is Konarak, and others also. The ancient sun temples actually created centering around leper colony. Leper is not a word, is a banned word now. Okay, we cannot say them leper. So whatever, lepra colony or the sun temples have been established. There is a Bengali novel, I don't know whether you have read it, that is Sambo, written by Kalkut. That was regarding who was Sambo, one son of Lord Krishna. He actually got affected by leprosy and he was cured where now Konarok is situated. Okay, also some leprosy colonies are in West Bengal also, some in Birbhum, some in Bankura, Purulia, always the hilly and hot region. Okay, not the humid, only heat, dry heat where it is, that's where leprosy colony you find. Why? Because by ancient text it was written that leprosy is cured by sunlight. Okay, it was by ancient text. Now in 1873 we all know leprosy is also known as Hansen's disease. So this is the German person Gerhard Hansen. He identified first the Mycobacterium leprae. Then in 1898 Britishers implemented the Lepers Act to make them socially totally outcast. That was the Lepers Act all about. And we all know about Mother Teresa. She actually first works on leprosy people. Okay, even Gandhi, there was a famous picture of Gandhiji, okay, doing care of leprosy patient. That part of Gujarat also, Sabarmati Ashram, that was also surrounding a leprosy colony. Now this is the logo of the leprosy. This is not a random logo. The everything has a meaning. First, the lotus, it represents purity, dignity and the social acceptance, which was missing on leprosy. Then this is the partially affected hand. It resembles a leprosy patient. Now it's also make as a shape as a house, na? Why it is? It represents care, and this is the rising sun. It represents hope and cure. That is the meaning of the logo. It's not a random logo. That's why it is much asked. Now 1948 British Empire Relief Association, first renamed as Hindu Kush Nivaran Sangh. It was presided over our Mahatma Gandhi. Okay. In 1955, the Leprosy Control Program, National Leprosy Control Program or NLCP. Now in 1982, we first introduced MDT. Okay. I have marked this because it has been asked sometimes. Okay. In 1983, the name NLEP. Okay. Then NLEP 2001-2004 NLEP project phase 2. In 2005, India achieved national elimination status. Okay. In epidemiology, you will study when it is called elimination, when it is eradication. I think you have now all have studied. Okay. And 2023-27, that's a roadmap, national strategic plan, where in 2025 we have introduced the newest regimen. Okay. Now this was the vision, a leprosy-free India, which is not possible probably. Just like a vision, it is not achievable, but we work towards it. Now coming to the mission to promote quality, free and accessible leprosy services. Then core objective, district level elimination, at least prevalence less than 1 per 10,000. Protect children, 0 grade 2 disability. What is grade 2 disability? I will come to it later. Now minimize the disability, reduces grade 2 disability cases, and finally just like TB, end the stigma. Okay. In some objectives and some things, NLEP and NTEP is almost same. Okay. So try to read it simultaneously. Then what are the core strategies? Targeted prevalence reduction, community-led case finding, awareness and stigma reduction, intensive monitoring, disability prevention, early detection and treatment. To achieve these core strategies, what kind of services are given? It will come later. So first, for early case detection, what are the case detection and management? Positive identification is case now through survey and screening. Okay. Usually leprosy affected people leads to a leprosy colony. But what we try to employing, that ASHA workers are screening the villages. In urban area it is not possible. Urban area we assume that people are much more educated, so they will come their own, but in rural area ASHA workers screen for hypopigmented patch, ask for also screen for if there is any hypopigmented patch, and they got trained to give them correct referral to go to this place or that place. If leprosy training center is leprosy center is there, you go to that or refer to where leprosy cases much more referred to. Which department? If it's a medical college, dermatology. Okay. Now and disability prevention and rehabilitation. Okay. Previously, for grade 2 disability, we have not rehabilitation was there, but it was very expensive. Now we have for foot or hand, artificial prosthetics have been made in our own country. You all read about in Ortho Jaipur foot, na? Now India make in India and used in, and actually it is made by leprosy affected patients also. Okay, there is one private government collaboration in TLM. Okay, that is leprosy. LM is for leprosy mission. It is actually led by missionaries. They actually gave vocational training to sons or family members, even the leprosy patients who have lesser disability. They made, actually they make these prosthetics for hand, foot also, and we have some leprosy hospitals in the West Bengal, one in Howrah, another one in Bankura. Okay, in Bankura there is national level RLTRI, that is Regional Leprosy Training and Research Institute. বাঁকুড়া থেকে কেউ আছে হ্যাঁ না? গৌরীপুর, ইউ নো না গৌরীপুর, বাঁকুড়া ডিস্ট্রিক্ট, বাঁকুড়া টাউনের বাইরে গৌরীপুর, ডোন্ট নো বাঁকুড়া টাউনের থেকে হোয়াট এভার, only 5 kilometer outside. Okay, so that Gauripur, there was one operation theater also, that is where every day 1 or 2 prosthetic implant is done. Okay, fitting also. Now this is the organogram. What are the central level? We have the MOHFW and DGHS, okay, and Central Leprosy Division. At state level there is one DHS and junior DHS for TB and leprosy both. What are their functions? They are all for monitoring and reporting and policy implementation. In district level we have District Health Society, District Leprosy Officer or DLO. For TB also we have DTO and some district nucleus team. They actually inquire about the work, about how ASA workers are doing, or how the screening has been done. Okay, at block level and PHC level we have Rogi Kollan Samiti, and block medical officer is the in charge of TB unit and leprosy unit also. In sub center or Gram Panchayat level we have Gram Panchayat. They are actually made, they actually run the awareness programs to reduce the stigma and also encourage people to for screening, and who is the worker, that is male, female worker or male or female health worker. Okay, and village level we all know about the village VHSND, village health and sanitation day, arranged by village health and sanitation committee and ASA or AWW. Okay, what are the activities now? Free diagnosis and treatment, revised treatment protocol as per 1st April 2025, capacity building, that is training. Every year all ASA workers are trained about detection and the treatment regimen. Only detection, treatment is not there in their capacity. At least the screening regimen, screening procedures every year in a phased manner. Okay, this is a central run program. And IC counseling, disability prevention and rehabilitation, and finally supervision and monitoring. It is done by head of the institution always. Okay, now coming to your clinical part, that is the revised classification. Okay, now Paucibacillary when 1 to 5 lesion, no nerve involved and absent. Very previously it was, if there is any lesion, then it was multibacillary. But now we have revised the classification. Now 1 to 5 for multibacillary, for more than 5, 1 or more nerve involved, and bacilli in slit-skin smear has to be there. Okay, what is the gold standard diagnostic technique? Skin biopsy with slit-skin smear for HPE. How the HPE looks like should be? It is acid fast and spherical, rod, comma, rod shaped. Then how do we differentiate from it is not skin TB? How we differentiate MTB or M. leprae? Using only the microscopy. It is slit-skin smear. Sometimes it is, I am totally omitting the clinical features. You got a slit-skin smear, and you detect one acid-fast bacilli. Well, is it MTB or M. leprae? How to differentiate? H2SO4 এর কনসেন্ট্রেশনে কিছু ছিল? আমি পরীক্ষা দেব। হ্যাঁ, পড়ে নাও, নইলে এত না পড়া, এত হাসি সব একদিন চলে যাবে। কদিন পরে ইন্টার্নশিপ, তারপর সমুদ্রে পড়বে বাইরে বেরিয়ে। ওকে, coming to the treatment regimen, it is again the same for dapsone and clofazimine, but rifampicin has been added for for Paucibacillary 10 to 14 years 450, child less than 10 years or 20 to 40 kilogram, it is 10 mg per kg once monthly. Always remember rifampicin is once a monthly, okay. And what is for multibacillary? Again clofazimine, dapsone and rifampicin, but duration is different. Pauci is 6, multibacillary 12 months, okay. This is the picture, okay. I do not find the current picture actually because rifampicin once a month, so it is actually given separately probably, or new blister pack has not been here. But remember the color code. Paucibacillary adult is green, Paucibacillary child is blue, multibacillary adult is, what is this, red or maroon, whatever you say, and this is also, I don't know about this color, okay, golden even. This is what, this is the color actually, okay. So it will be present in your exam. Right now we do not have, but it will be present in final exam, okay. Don't say anything, because, and also remember in which day what is to take, it is actually written in the back of that blister pack, okay. Day 1 to day 30, sorry, day 28, it is written 1 to 1 2 3 4 ऐसे करके. Now what is the disability? Disability we have grade 0, grade 1 and grade 2. Focus on the marked line, that is, this is associated with complete recovery without physical impairment and key indicator of effective surveillance and early intervention. So if we ask about supervision and monitoring, where we will focus the effectiveness of the treatment, that is this, how much grade 2 disability, sorry, grade 2, how much grade 0 disability has been cured, okay. Again grade 1, critical window for early intervention, grade 1 is acceptable. If we intervene here, if we identify the patient here, we can treat them up to grade 0. That's why it is the critical point. We have to intervene here. If the patient gets to grade 2, we do not have any secondary intervention. We always have to go for then tertiary, that is giving them prosthesis and also rehab. It is also reflects the need for prompt treatment and monitoring, prevention, progression, and for grade 2 there are reflect delayed diagnosis, key indicator of program performance under NLEP. So the lesser the grade 2 disability, the better the program is performing, okay. The grade 2 disability numbers should be much less, and it also highlights the need for strengthening the early detection. If there is too much grade 2 disability in a region, what it means, the ASHA workers are not doing their work. They failed to detect when the patient was on grade 1. Understand na what I am saying? Please try to understand. Not every one of you will get to MBBS, but MBBS obviously, MD, DNB, some will go into administration, medical administration. That's also a place where you can make some change. Actually you can become renowned, okay. পয়সা সবার হবে, কিন্তু যদি বইয়ের পাতায় নিজের একটা ছবি উঠে যায়, that is also great. Whoever we actually see, those all were somewhat administrator, okay. Just a small reference. Who mapped the length of Mount Everest? On Bengali, but the mount is named Mount Radhanath. Who was Everest? His boss. So becoming boss is also good. Okay. These are the same again enhanced strategies, whatever they are, major innovation that revised if it is asked in your Viva, the major innovations launched in 2025, not only this revised 3-drug regimen, again the just like NICSAI, we have now NICUST 2.0 digital portal and the post-exposure prophylaxis. The post-exposure prophylaxis is usually given to close contacts, that means sometimes family members of a leprosy patient, okay. And this is now a notifiable disease status. Previously it was for TB and there was 15. Kushto was notifiable, but now it is implemented strongly. What is the IPC of if you fail to notify a notifiable disease? What is the IPC involved if you failed to notify a notifiable disease? Anyone? FMT to ei year e ache. Sir, edik theke kichu? Samner benche, sir. What is the IPC involved that if you fail to notify a notifiable disease, you will be punished in which IPC? 269 is if you fail to, you will be charged in IPC 269 and you will be punished in IPC 270. ঠিক আছে? This is practical, always remember. Okay? You do not need this actually. You can read, I will share the PPT, but you can read it. And what are the challenges? That is persistent transmission, just like TB. The source is again in the soil, so it is very much difficult. Also there are stigma and discrimination still, that's why we still have the leprosy colonies and hidden and child cases. In leprosy cases, childs are usually ignored, okay. Children cannot understand, but it is the job of their parents to identify if there is any hypopigmented patch is going or not. And it is leprosy detection is not done in school. There is no program, so teachers not even trained. There is a planning to introduce for screening of TB and leprosy in the school to identify the TB or leprosy case, hidden TB and leprosy cases. Yesterday was NTV Day, National TV Day. There was a CME in downstairs, okay. There your deans have said that leprosy is now even seen in upper strata people. It's not now a disease of the poor. It is always previously and now still this is a disease of the malnourished. So those who are not eating properly, not getting proper micronutrients, you can get TB, okay. That's why TB cases and leprosy cases are now seen in upper strata people also, upper socioeconomic section. And also there are post-treatment care gaps, complacency is low because dapsone and clofazimine, just like TB, these are also highly toxic drug, okay. These are the way how we can get into, how we can reach the finish line. For SDG, 2030 is also the end of year of ending of leprosy. We are nowhere near that, okay. That's why the National Strategic Plan 2023 to 27 was that much important. These are the targets for leprosy free India. It is sometimes asked that zero child case, reduced disability rate, early case detection, universal MDT access. MDT is not easily found. It is MDT and medication for TB. It is easily not found in the private sector, okay. Because it is totally given free in government sector, it is not available. But we and nowadays sometimes it is not available at every government facility, okay. We have to try to make it available. And enhanced control, tracing, elimination of stigma, all these things are there. In your exam, there will be one blister either for paucibacillary adult, paucibacillary children, or multibacillary adult, multibacillary children. Okay, first identify that the drugs are for leprosy, then identify, okay, if it is leprosy then there is a specific color code. Even for TB, that is a specific, there is a specific color code. Okay, the green for sometimes intensified or and sensitive, actually it is written, the color code is not universal there, but here the color code is universal. Okay, then okay, there is the color code there, what the drugs are for, and now dose, and then the examiner will go to leprosy, NLEP or the pathology, anywhere. Try to study like that, and I have shared a TB poster at a glance. Try to make NLEP same like that. Okay, Sapna ki, that is the, now it is the mascot of National Leprosy Eradication Program, symbolizing hope, awareness and India's commitment for a leprosy free India. This is the picture. Mahatma Gandhi is not a nursing a leprosy patient. Okay, it is asked in MCQ exams also. Okay, and ratio numerator and denominator is always different. It can be seen as a proportion with a time dimension. You can see it like that. Okay, what is rate? Rate mass, these are the inclusions, you can read on that. What is the risk? That likelihood the person will contract a disease, that is the risk. Okay, from there we actually estimate the attack rate and secondary attack rate. These are also measures of morbidity. Now coming to the incidence and prevalence. Incidence is number of new cases. It might be at a point time or at a period of time. Depending on that, we have two types of incidence. One is cumulative incidence, one is incidence density. You usually deals with incidence density. Okay, for incidence density the unit is always person years. And prevalence, prevalence is existing cases plus new cases at a period of time. Prevalence is also two types, at a point of time, that is point prevalence, and if the thing is followed up or observed for a period of time, in cohort we actually measure that period prevalence, and cross section we measure, cross sectional study we measure point prevalence or point incidence also, if we are what we are seeing new cases or all cases. Okay, this is also all are ki fast hocche to jono you said about na jono ki fast hocche, all things are in the PPT, so please go through by it when it will be shared. Cumulative, so what is the cumulative number of new cases during a specified period of time divided by total population at risk in the specified period of time. তাহলে যদি বলা হয় যে if a population was observed for 2-year period, okay, there was 500, the total population was 10,000, there was 500 diabetics at the start of onset of the study. At the end of 1 year বলেছি আমি 1 year observe হয়েছে, at the end of 1 year there was 700 cases of diabetes. So what is the cumulative incidence? 10,000 population, 10,000 population এ 700 জন ছিল, প্রথমে 500 জন ছিল, পরে 700 হয়েছে, তাহলে 200 নিউ কেস, 200 divided by 10,000, ঠিক আছে, that is cumulative. And if we are talking about incidence density, when multiple people are observed for multiple variation of time, now suppose we are watching over a town, okay, a town is multiple wards, one ward for 1 year, another ward for 8 months, another ward for 11 months, we watched a different type of observed time. So at the end of the day, how we measure the incidence? We take into person years, or how many persons is watched over for how many time, and we use that as a denominator for the instead of total population. Simple thing. And incidence density, it will be not asked. Cumulative incidence is usually asked. Okay. This is the percentile number of cases during the observation period, time each person was observed. Okay. Just if you want to be clear, please, today is not the time. Please come after the semester, because these are the questions is now asked in INICET. Okay. Those who are interested, please contact. Okay. Now that special type of incidence was attack rate and secondary attack rate. What is attack rate? Number of new cases among the population. Now we are talking about population at risk. Here the trick part is coming. We all know about polio. Does polio affect adults? No. So when the question will come in a family of 5, one children got affected by polio, what is the attack rate? What is the secondary attack rate? How can there whom you will exclude? Obviously the parents. So 2 will be instant minus. And for secondary attack rate, we all know the index case should be excluded even. So it will be 2 by, what is the secondary number persons exposed divided by total number of susceptible into 10 to the power n. But secondary attack rate is also, we have to, in practicality, we have to remove the index case. Okay. So what will be the secondary attack rate? Family 2 by 2 na. That's why polio is 100 secondary attack rate. Same, actually not polio. Measles have 100% secondary attack rate, remember. Okay. Now coming to the prevalence, that is amount of disease that is already present, all new and pre-existed case at a time dimension, whatever. If it's a point of time, that is point prevalence, period of time, period prevalence. Okay. What are the use to determine the workload planning and for monitoring? Okay. Point prevalence is a point, 1 point by divided by total population. What are the factors affecting prevalence? Obviously those simple one, remember 1 point if it is asked in your viva, that those disease who have one definite phase, either cured or died, that those have less prevalence. Okay. Because in a population, if we get contacted by, suppose rabies, in a population, rabies has definite result that it will be death. Okay. Rabies has 100% mortality, or tetanus. So their prevalence will be less because there will be only cases and very few past cases. But if it's a non-communicable disease such as diabetes, there will be previous cases and newer cases. So the burden will be higher and prevalence will be higher. Okay. Period prevalence, it is a period of a time, but it is not asked. Okay. These are the difference. Baki, our problem karo ache, then answer me only one question. If we go by simultaneous testing, what will be the net sensitivity? Increase or decrease? And what will be the net specificity? What will be the, if we go by sequential, this is the kind of question you will ask in your NEET PG. Okay. Not the easiest ABCD and what is the sensitivity and specificity. And always read about what likelihood ratio and bias theorem.